Hello and good evening, and welcome to Insight Memory Care's special event about Lewy body dementia and current research studies. Our mission here is to provide specialized care, support, and education for individuals in all stages of memory and cognitive impairment, their partners, and our community. Our vision, a community where those living with memory or cognitive impairment and their care partners can achieve the highest quality of life. This evening, we are excited to have Dr. Keith Fargo with us. He's the Director of Scientific Initiatives at the Lewy Body Dementia Association. And Dr. Fargo earned his PhD in neuroscience from Indiana University, where his research focused on the effects of hormones on the structure and the function of spinal cord neurons that control movement. In his current role at the Lewy Body Association, he is responsible for the research activities of LBDA, including the flagship LBDA Research Center of Excellence, a network of 20 of the nation's leading academic medical institutions focused on advancing our understanding of the disease, improving care, and caring for our clinical trials for Lewy body dementia. We are very excited to have him. And just a couple housekeeping things before he comes on to join us. We will be recording this. Please put any of your questions into the Q&A, and we will ask them as they pop up so that they're within context, because he has lots of information to share. But thank you so much for joining us, Dr. Fargo, and you may go ahead and share your screen and get started.
Great. Thanks, Melissa. I appreciate the kind introduction and also the invitation to present. And thanks to everybody who's joining us here today and who may watch us later as well. So without further ado, I will go ahead and share my screen. All right. And then, Melissa, can you just confirm that you're seeing the title slide and that it's in?
I am. You are
Okay,
all
great.
set.
Thank you very much. All right, so this is me, as Melissa mentioned, and I'm going to start by talking just a little bit about some of the programs and services that LBDA offers, because it's very clear to me that if you're here joining the webinar today, you may know someone or have LBD yourself. And so I want to make sure that we let you know what LBDA has to offer you as the sole national nonprofit that's focused only on improving quality of life for people with Lewy body dementia. And I also want to say that, I don't have this in the slide deck, but I think it's important, level setting as well. When we talk about Lewy body dementia, we're really talking about two different forms of dementia, both of which are characterized by the presence of Lewy bodies in the brain. And I'll actually show you some pictures later on about what Lewy bodies are. But the reason I want to make that point is that some people have dementia with Lewy bodies, which sounds a lot like I just said Lewy body dementia, but it's slightly different. Lewy body dementia is the umbrella term for dementia with Lewy bodies, and that's what happens when you have Lewy bodies in your brain and you start to experience dementia symptoms before you start to experience other symptoms that are associated with Lewy bodies. And the primary other kind of symptom that people experience related to Lewy bodies is Parkinsonism. And so the other disease that people will develop based on the presence of Lewy bodies in their brain is Parkinson's disease. But what might be a surprise to any of you who are familiar with Parkinson's disease is that if a person lives long enough with Parkinson's disease, up to 80% of them will also develop dementia as part of that Parkinson's disease, because again, they have the Lewy bodies in the brain. In that case, we call the dementia Parkinson's disease dementia, or PDD. So a really easy way to keep that straight is to think about LBD equals PDD plus DLB. So regardless of whether you have the dementia symptoms before you develop any kind of Parkinsonism, and you may not ever develop any Parkinsonism with DLB, or if you have the Parkinson's disease first and develop dementia on top of that, both of those are considered Lewy body dementia, or LBD. And we provide services and supports and for people with both DLB and with PDD. So it's Lewy Body Dementia Association. covering both of those diseases. So first, I wanted to share with you some of the educational resources that we provide for families or for people with LBD. And so you can see here you can go to lbda.org and you can request free publications that we'll send right to your house. There are plenty of things that you can download there as well. I also want to let you know that we have an on-demand online learning system, and that's called the Lewy Learning Center. So we have lots of topics that we cover there, including research topics, but also topics about everyday life and how to cope and how to plan for the future if you're living with LBD. And so I think this presentation will be shared, at least the recording will be, so you should be able to come back and find this link. So we'll move on from that now. If we have any healthcare providers joining us today, especially prescribers, I do want to let you know that probably the single most important thing that we make available for you, for your patients, is the Diamond Lewy Management Kit. Now, Lewy body dementia is a complex disease, and there are many symptom domains even outside of what we think about usually, which is cognition. Yeah? But people can also have problems with their autonomic nervous system that can lead to balance issues and fainting. It's very common for people to have what are typically thought of as neuropsychiatric symptoms, such as hallucinations and delusions, as part of Lewy body dementia as well. Thankfully, those tend not to be frightening for people with LBD, although in some cases they are. And then there are sleep disorders that go along with LBD, so many different symptom domains. And what the Diamond Lewy Management Toolkit does is it breaks down each of those symptom domains for the prescriber and gives you some recommendations about how to approach treating those different symptoms. Many of them start with non-pharmaceutical treatment options, but then, of course, we also follow through with talking about the different pharmaceutical treatment options, dose ranges to try, and, of course, medications to avoid. One of the things that's different about Lewy body dementia from other forms of dementia is that it comes with something called neuroleptic sensitivity syndrome. And so many people, if they take medications that we tend to call antipsychotics, if they have Lewy body dementia, can have very negative reactions to some of those antipsychotics, including, unfortunately, up to potentially dying from being treated with Haldol, for example. But there are options that are not Haldol and are not some of those older antipsychotics that are much safer for people with living with LBD today. And so this is a really great toolkit for any of you who might be overseeing or managing care for people with LBD. If we're joined today by any allied health professionals, which I've noticed that we tend to be when we have community webinars, I also want to let you know that we have educational opportunities available for people who are allied healthcare professionals. And you can see that here. And specifically, we offer a course on the role of the physical therapist, the occupational therapist, and the speech language pathologist in providing person-centered care for people with LBD. Also, in addition to doing webinars like this for Insight, and again, thank you for the invitation, we really appreciate that. We host a number of our own webinars at LBDA, and all of those webinars, after they are recorded, are made available on YouTube on the LBDA TV channel. So you can simply go to YouTube and do a search for LBDA TV, and you will find our channel. Or if you'd like to, you can simply utilize this QR code. I'm not going to leave it on screen right now, but when you get the recording, you'll have a chance to do that. Finally, if you are experiencing crisis right now, or you think you would like to avoid, you can see a crisis, potentially forming for the future and want to avoid that, I would really encourage you to reach out to our support team at LBDA as well. It's staffed by social workers, and it's not 24/7, but please, if you call and you don't get an answer, please do leave a message, and they make every effort to return each call within 24 hours. And then, of course, we have support groups on Facebook for people who don't live close to an in-person support group. But we also do have in-person support groups, approximately 100 of them spread throughout the country. And you can find those support groups and information about the Facebook support groups as well by visiting our website and just looking under support on the navigation bar, and you'll find all of that information. The last thing I want to talk to you about here before we get into some of the research is another program that we offer. This is called the Research Centers of Excellence. There are approximately 20 of these spread across the United States. Well, officially, there are about 20 of them. I can tell you that we have recently approved 7 additional research centers of excellence under this program, and one of them is in Virginia, actually at VCU. I think several of you might be joining from Virginia today. So keep an eye out for that. We'll be announcing that on our website soon. But they already have the stamp of approval from us. So if you see someone at VCU, please know that they are one of our newest research centers of excellence. And now I'm going to I guess switch gears a little bit here, and I'm going to talk a little bit about clinical trials and clinical research. And so what I'm showing you here to start this discussion with is an illustration of the process that it takes to get a drug from an idea to your doctor's office. So all medications and pharmaceutical treatment approaches start with an idea in basic research. And when we say basic research, we don't mean simple, we mean fundamental research that really helps us understand the disease process, what's happening in the body, what's happening with different molecular pathways in the brain. And the reason we want to understand those things is because it gives us targets. Once we understand those processes, we can figure out, okay, well, here's a molecule that we know changes in LBD, so maybe we can target that molecule, stop it from changing, and that might slow down or halt LBD, right? That's just an example. But the point is that we start with basic research. And then scientists go into drug discovery, which is next. And I hope you all can see my pointer here. Melissa, can you verify if people can see my pointer moving?
Yes.
Okay, thank you very much. All right. So then things move to drug discovery, and that's where, okay, now you have a target. What tool can we use to affect that target? What chemicals do we have in our arsenal that might actually change something about that target? And that might become a medication down the line. After drug discovery, you move into what we call preclinical research. And preclinical research really involves models, and that means either cells in a dish or model animals. And I know that animal research is controversial, but scientists consider it an ethical requirement that before testing a new medication in people, scientists consider it ethically necessary to test that medication in animals first. Because if there are things that we don't understand about it and it might cause harm, we would rather learn that by testing in rats and mice than learn that by testing in people. So we go through the preclinical testing first, and then once everything looks safe and like the drug may be effective, then we start with clinical trials. And that clinical trial simply means a trial or trying the medication in a clinical population. And clinical population just means human beings. So once we're ready to try a medication in human beings, that is a clinical trial. Those start with phase 1. And you'll notice here, by the way, I should talk about this funnel here, and you'll notice it's getting smaller and smaller with every step, right? So in drug discovery, there are lots of ideas about what might work. You get into that preclinical testing, you find out some look promising, some really don't look so promising based on the animal trials, and then you get into the human trials, And again, a lot of drugs are going to fail in phase 1 or we find out that they're not safe in people like we expected. Some will go through to phase 2. Phase 2 tends to be a slightly larger clinical trial, and the focus in phase 2 is still on safety, but that's where you also start to look a little bit for effectiveness. So in a phase 2 trial, that's when you'll start to add in some of these clinical assessments. How is the person feeling? Is something changing in their blood work that we can measure? Is something changing on a brain scan that we can measure that seems to correlate with functioning better? So you're starting to look not just at safety, but at effectiveness. And then if things still look good after phase 2, and by the way, I'm spending so much time talking to you about this because I'm going to describe the results of a couple of phase 2 trials here in a moment. And I just want to make sure everybody's kind of on the same page when we get there. So if things still look good in phase 2, then people will move into phase 3. And a phase 3 trial is usually much larger. In the case of a very, very common disease like heart disease or cancer, or a very common cancer, you may have up to thousands of participants in the trial. In the case of Lewy body disease, for a phase 3 trial, we're probably looking in the range of 300 to 500 people potentially. And for the phase 2 trials, we're usually looking at between 100 and 200 people for those phase 2 trials. In phase 3, that's where you prove, either this works and is safe, or it doesn't work or is not safe. And usually the FDA is going to require 2 completed phase 3 trials before they approve a medication. That's not always the case, but that's a rule of thumb. So once you get through phase 3, that's when you submit your application to the FDA to be allowed to market this as a medication. This NDA, BLA, you don't have to, there won't be a test, but NDA is new drug application, BLA is biological license or biologic license application. Because not all medications these days are what we think of as traditional drugs. Some of them are really biological molecules, such as antibodies, right? And so that wouldn't fall under new drug application, that would fall under a biologic license application. But then the FDA reviews those. That usually takes anywhere from 10 months to a year because they do a very, very thorough job of reviewing all of the data associated with all of the trials of the drug. And then they also bring in outside experts and advisors to also advise the FDA, what do we think as sort of usually academic experts will be doing that. And so the FDA has to take all of that into account before they make a decision on a medication. And even after that, we sometimes do what are called phase 4 trials. And that is post-approval research or monitoring. So now a new drug is on the market. Let's continue to follow that and see what happens to the people who are taking that new medication. Because you can oftentimes find, because now you're talking about thousands, potentially tens or hundreds of thousands of people taking a medication. And so you might find things even after the clinical trials. You might find very rare side effects, et cetera, that are important to know. So now what I'm going to do is I'm actually going to take you through the results of 2 major phase 2 clinical trials for dementia with Lewy bodies. In this case, these are DLB, not PDD, trials that both completed at the end of last year in 2024. Now, I know pharmaceutical companies don't always engender the best reputation for themselves, but one of the really nice things about working in the United States with the pharmaceutical companies that we have here is that there are rules about how they have to behave. And one of the rules is that they have to report their results of their trials publicly. So usually when a trial ends, within a month or 2, the company is going to present those results publicly so that they are informing potential investors. Believe it or not, these are actually rules around Securities and Exchange Commission. So these are more about protecting investors, but that helps patients and it helps the public because we can all see these results as well. And so I'm going to show you some slides that were taken from presentations that were made by the drug companies that ran these trials, because like I said, they're public information now, so I can share them with you. So this first one is called the Shimmer trial, and this was a trial of a drug with the interesting name, let's say, of CT1812. And it's really common when medications are very early in their development that they don't really have a name yet. They're often given some kind of a number or a code like this to identify them. So the CT stands for Cognition Therapeutics. That's the company that ran this trial. And then the 1812, I'm not sure exactly how they're using the numbers, but this particular molecule that will get a drug name later is being identified by them as 1812 at this time. So it's a trial of CT1812 in DLB. And I think the important thing that I want you to take away from this slide is that there were two different dosages used. Some people received 300 milligrams of the medication. Some people received 100 milligrams of the medication. And some people received a placebo. And the placebo, if you're not familiar with that concept yet, is just basically a sugar pill. And the reason we have to use placebo, again, is it really is for ethical reasons. Some people may say, well, is it not unethical to give somebody a sugar pill if you know they have a condition that you're trying to treat? Well, that is why clinical trials are always voluntary. If you're ever pressured to be in a clinical trial, push back because you have rights, and it's always voluntary to participate in a trial, and you must be made aware of the risks and potential benefits of participating before you agree. One of those risks is that you might be put on a placebo. But the reason that we have to do that is because we find that, believe it or not, people respond to placebo. So you give people a sugar pill, and some of them get better, actually. So the placebo effect is a very, very powerful psychological effect that we cannot, of our own accord, do away with. So if you're, it's so powerful that even if you know, even if you're told that you're being given a placebo, you still might feel better. That's how strong the placebo effect is. So the only way that we can truly know if the medication is working as a medication and not just working based on the placebo effect is to also have a placebo group. So if your placebo group gets better, you need your medication group to get even better than that to know that it's really a medication effect and not just a placebo effect. All right, and then these were some of the assessments that were done in the trial. Many different assessments here, and I won't go through all of these initialisms and what they mean, but we will talk about a few of them as we go through some further slides here. So I'm going to take you through some of the really promising results from this study. Not every measure came out promising, but many of them did. And first, I want to orient you to what these slides are going to look like. So in each case, you're going to see a graph, we call this the y-axis on the left, and that's going to show numerical change, either improvement or worsening. In this case, for all three of these, as you go down on the scale, that indicates worsening. Staying the same on the scale would indicate not worsening. Going up on the scale in this case would actually indicate an improvement. And the other thing I'm going to show you in these first few slides is I'll show you different lines for the 100 milligram group, and those are these purple lines with triangles, and then a reddish line, maybe it's pink, reddish line there with square markers, and that represents the 300 milligram group. And then later, though, because in many cases those groups are very, very similar, I'm actually going to show you pooled data, but I'll let you know when that comes. Okay. All right. So what we were taking a look at here first CDR is the name of an assessment that is used in not all, but the vast majority of clinical trials for dementia use the CDR scale as what they call their primary outcome, or in other words, the most important outcome to see, is this drug working? And it stands for the Clinical Dementia Rating Scale, or CDR. And in this case, we've got, oh, you know what? Actually, I take that back. For this particular trial, they were using a different CDR. So this is not actually the Clinical Dementia Rating Scale. This CDR stands for a scale called Cognitive Drug Research. So a different CDR, but it's still measuring cognition. And you can break cognition out into a number of different factors. Here we have episodic secondary memory, there's working memory, there's quality of memory. There are lots of different things that you can measure about a person's memory. And I also want to say memory is not the only kind of cognition. And as a matter of fact, in LBD, it's not even necessarily the primary kind of cognition that people first start to have problems with. In LBD, not always, but usually people will begin to have issues with planning, judgment, decision making, these things that we call executive function. So not necessarily memory, but being able to hold lots of different ideas together in your mind at the same time, follow a multi-step plan, etc. So memory oftentimes is not actually the issue in cognition and Lewy body dementia. Although if you live long enough with Lewy body dementia, chances are you will experience some memory decline as well. Well, in this case, these graphs are a little bit difficult to interpret, right? This one on the left seems fairly clear. If you got the placebo, this measure of memory continued to worsen over the course of the study, which was about half a year. And if you were on either one of the treatment groups, either the 100 milligram or the 300 milligram, it looks like you didn't really see that decline in that domain of memory. Now, when we get over here to these other two measures, these are bouncing all over the place, right? So when we look at the purple line there, that's the lower dose. They seem to have a benefit at week 14, but drop down, still doing better than placebo at week 26, but lower than where they started. Pretty similar pattern over here with this measure of memory as well. But then you'll notice the 300 milligram group, they actually did a little bit worse than placebo in this measure at the 14-week group, and then bounced back up to be better than placebo at the 26-week time point. Pretty similar pattern over here with this one. So that's the reason why I'm showing you these different dosing lines when it makes a difference. Because on this next slide, I'm going to show you the pooled data. And in this case, the pooled data looks a little bit cleaner, I think, than the individual group data. So here's the treatment arms pooled together. And they did that so that they could calculate these percent slowing, right? So among the treated groups versus the placebo group on this measure of memory, they saw an 85% slowing of decline. Then for this measure, 59% slowing. For this measure, 72% slowing. But like I said, let's go back and take a look at that graph before. Maybe not quite as clear when you separate out those treatment groups. All right, so now this is showing impact on neuropsychiatric features. You should know that it's extremely common for almost everyone with dementia to have some kind of neuropsychiatric feature, whether that be depression or anxiety. And some of these things we think of as risk factors for later developing dementia. But the more we learn about dementia, we're actually now starting to think about some of these things, especially if they hit you later in life, as maybe even being sort of the initial presentation of the disease that's causing the dementia. So maybe a late life depression and anxiety is not necessarily predicting that you will get dementia later, or increasing your risk for dementia. It may be just really an early indicator of the underlying disease in the brain that is causing anxiety and depression now, but will eventually cause dementia. So these things are extremely important, even though we think about cognition first when we think about dementia. Some of the symptoms that are most bothersome to the person with dementia and or to their caregivers or other family members or friends are actually some of these neuropsychiatric features. And so the NPI, that is the Neuropsychiatric Inventory, and it's a questionnaire that asks people about a lot of different possible neuropsychiatric experiences they may be having. Importantly, and I'll show you some results on this in a moment, but importantly, it doesn't just ask the person who has dementia, it also asks their care partner, are you seeing this? And most importantly, are you experiencing distress from this? Because not everyone experiences distress from each one of these symptoms. Uh, and so what we saw in the for the person themselves with dementia, how were they doing? We saw some benefit for the anxiety symptoms, for delusions. Delusions are very strongly held beliefs that don't match up with reality. And so in Lewy body dementia, that might be something like someone is stealing from me, or you might have something where you believe that your loved one has been replaced by an imposter, for example. That's a delusion. Hallucinations are perceptual experiences that feel to you like they're sensory experiences. So that, for example, is seeing something that other people are not seeing, hearing something that other people are not hearing, etc. Luckily, in LBD, hallucinations are not always scary. I've talked to many people who they're seeing a former pet, for example, in their living room with them. Other times they can be scary and they can be quite disturbing to the care partners as well. So we saw benefit really in all three of those features that are important in LPD, and some of the others too. Although as you get closer and closer to this dotted line, that means it's less and less likely that the drug had a positive effect on that particular feature. Now I'm still showing you the split lines in this picture, but this is the last time I'm going to show you the split lines, because from here on out, the pooled lines match up quite well with the two individual treatment arm lines. So the next slide I'm going to show you right now is going to show the pooled data. There you go. So I'll just flip back and forth between those for a minute, and you can see how the pooled data matches really, really well with the individual treatment arm data. And that was the case for the rest of what I'm going to show you today. So we're going to switch here just to pooled data for the rest. And so what they found with the neuropsychiatric measures, they found that there was a 86% slowing of worsening in these important features, again, mostly driven in this case by anxiety, delusions, and hallucinations. Moving on to fluctuations. If you're not familiar with fluctuations in Lewy body dementia, it's extremely common. And this is true for many kinds of dementia, for people who have good days and bad days, right? So, but in Lewy body dementia, this is very, very pronounced. Not in everyone, but in most people. And so they can have, it can be minute to minute, it can be hour to hour, it can be day to day, it could even be week to week that people have these fluctuations, which makes it really difficult to measure cognition, unfortunately, in these trials. But one of the things we can measure is how are the fluctuations, because fluctuations are considered by most people to be a negative feature of LBD. And so you can see here there was a 91% slowing of worsening of fluctuations during the course of this trial. Moving on to caregiver distress. Again, remember I told you that the NPI, that neuropsychiatric inventory, measures both what the participant, the volunteer in the study, is experiencing, but also measures how their care partners are reacting to that and are they distressed by it. So we think this is an important measure as well, because all of these diseases that cause dementia, they're really family diseases in the sense that, of course, you as the individual are most affected, but everyone else around you is also affected in some way. And so it's important to us that we be providing support and research that helps not just the person with dementia, but also their critical friends and family who are providing usually unpaid care for them. And so here you can see there was a really nice benefit on caregiver distress from these neuropsychiatric features. And again, that was driven mostly by anxiety, delusions, hallucinations. But we also saw in the caregiver distress really nice benefit around depression. Caregivers were less distressed by depressive symptoms they were seeing from the people they were providing care for, and also around agitation here and depression here. So maybe the participants themselves didn't notice as much of an improvement there, but their care partners certainly did, to the point where they were less distressed themselves about what they were seeing in the person they were providing care for. And then finally, what we really want to know is not just how will you feel after you take medications. Are you going to feel better? We want to know, are you going to feel enough better that it actually makes your life easier, that you function better in the world? And that is something that's very important to the FDA as they're considering approving medications. They want to know not just that the person taking the medication will feel better, but also that they will function better. And usually the way that that is assessed is through something called ADLs, or activities of daily living. And the kinds of activities of daily living that usually get measured are very basic, sort of day-to-day personal care responsibilities. Are you still able to bathe yourself? Are you still able to dress yourself? Can you handle your own grooming without help, etc.? So your ability to really get along in the world doing these basic day-to-day activities, that's something the FDA wants to see before they approve a drug. And you can see here that while people did continue to get worse while taking this medication, if they were on one of the treatment arms, they had a 52% slowing of that worsening. So taking all of this together, we're looking at some improvements in cognition. We're looking at several improvements in neuropsychiatric functioning, including to the point that it helps with caregiver distress, and we're seeing benefit in function. You take all that together, this is a very promising phase 2 trial. Now, I have to be clear here, this is only a phase 2 trial. The FDA does not approve medications based on phase 2 trials. They want phase 3 trials, and that's appropriate because there were only, I think, about 150 people in this study. And what we see in 150 people in 3 different treatment arms, by the way, so we're talking about fewer than 50 in each, what you see with that small of a group may or may not be real. And the only way you're going to know if that's real is to test it in a much larger group in phase 3. So we know this company is seeking funding for a phase 3 trial, but we have not heard an announcement yet that one is coming. I'll tell you a little bit later about how to stay up to date on clinical trials. And I will also tell you right now that this was the longest section of the presentation. And the last thing I want to mention about this is that CT1812 was the old name, that was the code name essentially, and now this company has a generic name for this drug. It's called zervimesine. So if you're keeping an eye out to see when and if the phase 3 launches, you might want to keep an eye out for this name, ZERVIMESINE, zervimesine. My guess is you'll still be able to find it by searching for CT1812, but you might have an easier time if you use the generic name. Now that is not, well, I'm actually going to skip that. I was just going to talk a little bit about generic names versus brand names, but I don't think we need to do that today. I'm going to skip ahead now to the second clinical trial that I'm going to tell you some results about. This one also completed late last fall. And this one was interesting because the the actual trial itself, what's called the initial phase, where you have some people on placebo and some people taking the active treatment, the actual initial phase of this trial turned out to be negative. So they had done a prior phase 2 trial where they got positive results, and then they did this trial and got negative results. That happens. It might mean that the drug doesn't really work and the first time was a fluke, but it might mean that something else is happening and you should dig a little bit deeper to see what might be going on to have caused that mismatch between the two results. And interestingly, what they found in this study was that they were using the same drug capsules that they had used in their initial phase 2 trial, but now these drug capsules were several years older. And at each time point in this study, they were taking blood samples from the participants to see how much drug was actually making it into their system. And what they found out was that the old capsules that they did this trial with, they were only getting a drug concentration of 3.9 nanograms per milliliter in the blood, whereas in the prior phase 2, they were getting a drug concentration of 5 nanograms per milliliter in the blood. So that's more than a 20% decrease in the actual amount of actual drug that was making it into the blood. So they did some analysis of these capsules and found out that there had been some changes in, how long it takes them to dissolve, et cetera. Long story short, these old capsules were just not performing the way fresh capsules perform. So they ordered some fresh capsules that they're calling new capsules. And that's what they used in what we call the extension phase of this study. So some of you may be familiar that since we have to use placebos in the initial phase of most of these trials, a lot of drug companies want to follow that up with what's called an open label extension. And in the open label extension, everybody who is in the trial gets to use the study drug. No one is on placebo. So even if you were on placebo in the initial part of the study, you would be switched to the active drug for the open label extension so that everyone who volunteers gets a chance to benefit from that. Now, what's really so this is a graph here of what that looks like. So this is time going from left to right, and the initial phase of this study was about 16 weeks, and they were using placebo or they were using the old capsules in that study. Then we move into the open label extension phase, and that is a 32-week phase or 32-week study. And this is when they started to add in the new capsules. Now, very interestingly, all of the new capsules did not get added at once. So there was something of a natural experiment that happened here. Some people who we'll call group 1 received the old capsules all the way through the extension phase. Okay. Some people in group 2, who we'll call group 2, they received they received the old capsules up to the 16-week time point in the extension phase, and then started receiving new capsules. In group 3, people got the old capsules for the first 8 weeks and then were switched to the new capsules. In group 4, similarly, old capsules for the first 4 weeks and then switched to the new capsules. Group 5 got new capsules for the entirety of the extension phase. And so what this allows researchers to do now is to go back and compare how are people doing who started getting the new capsules compared to how they were doing when they were receiving the old capsules that, remember, crucially, were not delivering the same amount of study drug that they were actually trying to deliver, which is where the new capsules come in. So there's a lot on this slide, and I'm going to really draw your attention to just one thing. Okay, so bear with me. You will get these slides as part of the recording. So take your time to peruse these data. But I think the most important point that I want to draw your attention to is over here on the left-hand side of the slide. So the initial phase, remember, everybody was receiving either placebo or old capsules. and the placebo group is shown in dark blue on the left-hand side of this graph at 8 weeks into the study and at 16 weeks, sorry, into the study. And then this sort of lighter blue, it's still kind of a dark blue, but lighter blue those are the old capsules. So they were getting study drug, but they were not getting the drug concentration that was intended for this trial. And you can see there's, really no difference between the, drug treatment and placebo treated here, probably because the dose was lower. And you can see that both groups got worse over time, right? So whether you were on the placebo, you got a little worse over that first 16 weeks, or if you were on the old capsules, you still got a little worse over that first 16 weeks. And it looks like approximately the same amount. So really no benefit there from the old capsules. Now let's move over to the new capsules, or the extension phase, some of which is new capsules and some of which was old capsules. So I want to draw your eye here to the sort of, I guess, medium blue. Let's call it medium blue. The medium blue bars at 8 weeks, 16 weeks, now getting into the extension phase, 24 weeks rather, and 32 weeks. This is actually only 16 weeks of the extension phase, but 32 weeks from the very start of the initial phase of the study. And you can see if people were taking those old capsules, they continued to get worse. It looks like it might even be speeding up a little bit. And it's probably about on target with what you would see if you extended that placebo out over time as well. Now, look at what happened to the people who were taking the new capsules and now getting the full dose of the study drug, the full 5 nanograms per milliliter, which is the target concentration in the blood. You can see that by 24 weeks, they have started to separate out from the old capsules, and they're not getting worse as fast. Now, to be clear, everybody in this study still did get worse. And unfortunately, that's kind of where we are with dementia trials today. We're really trying to slow down or stop that progression. In the future, we may be ready to think about creative ways to reverse that progression. But right now, the sort of main thing that we're trying to do is halt that progression. And so even slowing is a benefit because you get more good time with your friends and family before the end of life. So you can see that slowed down and even much more significantly at 32 weeks. So again, very, very positive. Even though the initial phase 2 study looked like it was a negative study, I really want to commend these particular researchers for not, just resting there and saying, let's find out what happened and let's see if we can figure out, why there was a difference between the first 2 phase 2 trials and actually then figuring out what it was and continuing this research. Otherwise, this is a medication that may not have gone forward. It may have just been considered a failure in phase 2 and would have just dropped out of that funnel that I showed you earlier. So kudos to this research team. I do think it's important for you all to know that drug trials are not the only trials. There are also trials of caregiver interventions. There for caregivers to see if we can make caregiver lives better. There are trials of non-pharmacological interventions as well for people who have the disease. This one that I want to point out to you right now is an intervention for caregivers. And so if you're a care partner right now for someone with LBD, whether that be, in this case, it could be either DLB or PDD, this trial might be right for you. And this can be done anywhere from the comfort of your home in the United States. It doesn't have to be the continental United States. So territories are fine as well. And just know it's not a drug trial. Instead, it's trying a sort of relatively intensive support and education intervention along with peer mentoring, right? So hooking new caregivers up with people who have already gone through the process of providing care for someone with LBD. So if that's something of interest to you, I do encourage you to learn more by looking up Persevere at lbda.org. Now, I'm going to end here with just a few quick slides on how to find clinical trials. And then I'm going to tell you about probably the most exciting thing that's happening in LBD research today, but is not really ready yet for prime time in widespread clinical usage. So first, let's talk about finding clinical trials. One way you can do that is through the Lewy trial tracker. This essentially is a contact registry. So we ask you a few questions about what types of studies are you interested in? What kinds of procedures are you willing to undergo? What kinds of procedures do you not want to undergo? So for example, some people are going to tell us, I'm perfectly happy taking an experimental medication. Other people are going to tell us, I won't touch an experimental medication with a 10-foot pole. There are studies for both of those kinds of people that you can find through Lewy Trial Tracker. And so once we learn a few things about you, we never share that information with anybody else, period. Okay, but what we do is we use that information to know what kinds of trials to make you aware of. So, for example, if you say, I'm looking for a medication trial, the next time a medication trial opens up, if we know this about you because you've signed up for Lewy Trial Tracker, we can then notify you that that study is open, and then it's up to you to determine whether it's of interest. We're not going to send your name and information to the study team. We only send study information to you, and then if you're interested, you follow up with that study team. You can also simply go to our website and find the clinical studies listing page, and you can just peruse, through the clinical studies. What we try to do is only include studies here that are currently recruiting. So if you find a study here, they should be currently looking for volunteers. Occasionally one will slip through where they've stopped looking for volunteers and haven't told us yet. So you may have that experience, but we make every effort to make sure that the studies we list are currently seeking volunteers. So speaking of, I will also tell you that one of the other places that you can find clinical trials is through the federal government. So right now there's a place called clinicaltrials.gov that you can visit and search. Now the one drawback about this is that it's not really curated, so it might be difficult for you to find, exactly what you're looking for. And there are thousands and thousands of trials that are listed here. So I really would recommend you start with the LBDA website or some other website that's focused on dementia trials. And then if you're not seeing what you're looking for there, go ahead and give clinicaltrials.gov a shot, but just know that it's not as user-friendly. Finally, this is a callback to the Research Centers of Excellence. If you happen to, and you can find these on our website, if you happen to live near one, many of these are also running what are called single site or single center clinical trials that we don't list on our website because they may only be taking participants from, let's say, Dallas, right? Well, your average person isn't really going to benefit from that. But if you live in Dallas and you're near the Research Center of Excellence, you can find out information about the studies that they're running at those RCOEs as well. And I'm going to stop here with two more slides, and I hope you'll bear with me. I know we're running late on time here, but I wanted to talk about some really exciting things that are happening in research today. Many of you are probably familiar with Alzheimer's disease to a greater or lesser degree. This is a picture of Alois Alzheimer right here, who discovered the pathology associated with Alzheimer's disease. That's why it's named after him. It was around long before him, it just didn't have a name because he was the one who discovered what was happening in the brain. Well, standing two people over from him, this is Friedrich Lewy, also known as Fritz Lewy. This is the person who discovered Lewy bodies, which are associated with Lewy body dementia and Parkinson's disease. And here's an example of what that looks like inside a brain cell. Here's another example of what that looks like inside a brain cell. This is showing you the axons and dendrites. These are the sort of projections that come off of the main body of a brain cell and make it look very, sort of spiky and how they communicate with other cells. That's showing some of that Lewy pathology inside those neurites as well. So this was all based on microscopes though, and you had to wait until a person passed away to take out some of their brain tissue and look for these telltale signs. Well, just a few years ago, some really clever researchers discovered a way to measure this without taking the brain out. What they do is they take a very small sample of the cerebrospinal fluid. This is the fluid that surrounds your spinal cord and your brain and cushions them from, protects them from impact and many other things. But that's one of the things that we think about them doing. And it turns out that you can take a really small sample of that through a spinal tap. No real side effects to speak of, except some people might have a headache for a little while. There's always a risk of infection, anytime you have some kind of injection or somebody withdraws fluid from the body, but pretty safe, pretty well tolerated. And you can actually use that to tell now during life, who has Lewy bodies in their brain. This is a game changer because when we look at old clinical trials for people with LBD, many of those folks have gone on and passed away now, and we have their brains for autopsy. And what we find is 25 to 30% of those people that were in the DLB trials didn't actually have Lewy bodies in their brain. It just looked like they did based on their clinical symptoms. And so you can imagine it's really difficult to get good, high quality, effective medications if about 25 to 30% of the people in your trial don't even have the disease that you're trying to affect, right? So this ability now to tell with relative certainty during life who has Lewy bodies in their brain is revolutionizing the way that we can do clinical trials. And then I'm going to leave you, this is the final slide. This is also a new biomarker that may tell us who has Lewy body dementia or Parkinson's disease during life. And this is measuring another form of synuclein called phosphorylated synuclein in the skin. And you're seeing 2 images on the left and 2 images on the right. And in each case, the top image is showing red, and that is showing phosphorylated synuclein. And so then the question is, and this is in the skin, okay, but there's lots of things that happen in the skin. So then the question is, well, where is this in the skin? What structure is this phosphorylated synuclein associated with? So then you can do another stain that shows, and this particular stain shows nerves or nerve fibers in green. And when we do that, we can see that what's appearing here is phosphorylated synuclein inside one or more of the nerve fibers in these bundles of nerve fibers that travel through the skin. So just wanted to leave you with that as well. In addition to some of these exciting clinical trial results, we've got some really great new tools that researchers are now using to help speed progress even faster. So with that, I'm going to end. I know we're over by a minute, but I'm happy to stick around for a little while for questions if anyone has any.
Thank you so very much. If anyone does any questions, please put them in the Q&A, and I am happy to pop them up to him. And I will share my screen real quick while we're waiting for any questions to pop up. Just a reminder, we have plenty of upcoming events. If you missed the Spark event last Tuesday night, we're going to do it again in October. So please feel free to keep an eye out for that and sign up. But any of our other things, our support groups, other education, more than welcome to sign up for those. And last but not least, if you need to reach out, you can reach out to education, Q&A. Great information. Thank you. We had a lovely comment.
Thanks.
So this will be recorded. Please give us about a week to get it up so you can relook at it. But we want to thank you again for coming and sharing this information with us. And he and I have already talked about him coming next year because you know how I like to plan. So we are working on that. But feel free to let us know if you have any questions after the fact. I can always reach out to him later and take care of that. I hope you all have a wonderful evening. Thank you again for being here, and we will see you at our next event.
Thanks all. Take care. Bye-bye.